السلام عليكم يا جماعة. أتمنى تكونوا سامعيني ويكون الصوت كويس. أنا الحقيقة مش قادر آخد فيدباك. I will talk about our lecture today is about jaundice, and when I talk about something, I start by defining what I'm talking about. So, by definition, what is jaundice? Jaundice is yellow discoloration of the skin and mucous membranes due to rise of bilirubin in blood above normal levels. I have here some pictures, examples. Here is a newborn with yellowish discoloration of his whole skin because he's newborn. His skin is thin, and we can see the yellow discoloration in the whole body. Of an adult with mucous membranes under the surface of the tongue with yellowish discoloration. Another adult with his sclera showing yellowish discoloration. So these are examples of jaundice patients which show yellowish discoloration either of the skin, of their mucous membranes, or in the sclera when the bilirubin is above 2 to 3 milligrams per deciliter. Where did the name come from? The name jaundice, from the French language, jaune means yellow in the French language. So because it's yellowish discoloration, we call it jaundice from the term jaune in the French language. And we have another term for jaundice, which is icterus, coming from the old Greek language. It meant in the old Greek language, it means patients with jaundice, like we use it today. And they have some myths in the old Greeks. They know this bird, which has a yellow feather. It was called icterus glabella, and they thought when a patient sees the bird and the bird flies, he takes the yellow color from his eye, and the patient gets cured afterwards. And they named the disease itself icterus according to this bird, icterus glabella. Jaundice is yellowish discoloration due to rise of bilirubin. So let's start by reminding ourselves what was bilirubin. Bilirubin, as you studied in your biochemistry in second year biochemistry, bilirubin is the breakdown of heme moiety, of hemoglobin mainly in the reticuloendothelial system. We have other heme moieties in other tissues like cytochrome P450. But mainly, hemoglobin is the main source of bilirubin. The breakdown of hemoglobin is the main source of bilirubin in our body. When the heme enters the reticuloendothelial system, the broken heme, the old RBCs, the old hemoglobin, it gets converted to biliverdin first. And after being converted to biliverdin, it will be reduced to bilirubin, which we call unconjugated bilirubin. This type of bilirubin is not water soluble. It is carried by special carriers at the bloodstream, special protein inside the bloodstream to reach the liver. And inside the liver, it gets conjugated to glucuronic acid to form what we call conjugated bilirubin, which is now water soluble and can be excreted in the bile to the bile duct into the intestine. When it reaches the intestine, it travels all the way down the small intestine. At the terminal ileum, some of it gets absorbed and returns back to the liver through the portal circulation in the Intrahepatic circulation of bilirubin, while other parts gets into the colon and will be acted upon by the colonic bacteria to form stercobilin or stercobilinogen, which is further oxidized by the air to stercobilin, and this is responsible in part for the color of our stools. the part which was absorbed in the terminal ileum, when it gets to the liver, the liver uptakes this part and re-excretes it again in the bilirubin in the enterohepatic circulation. But some of it escapes the liver and reaches the kidney, where it is excreted in the kidney, and is known as urobilinogen. This slide shows the histology of the liver. The popular lobes of the liver, the architecture, which you studied in your histology classes. And when it is magnified, we see that we have the portal having a branch of the hepatic artery, a branch of the portal vein, and a branch of the bile duct, or a bile canaliculi. Blood comes from the portal circulation and enters through the hepatic sinusoids to reach the central canal, and on its way, it finds the porphyry cell, part of the reticuloendothelial system, which can take up broken heme, converting it to bilirubin, and then it will find the hepatocyte on the other side, gives this to the hepatocyte to get conjugated, and after being conjugated, it will be excreted in the bile canaliculi, which are adjacent to the other side of the hepatocytes. So all the machinery of the whole metabolism are in close vicinity to each other. They are all in the liver tissue. When we speak about hyperbilirubinemia, we can classify it broadly into unconjugated and conjugated hyperbilirubinemia. Which type is responsible for the elevation? Is it the unconjugated part or the conjugated part? The unconjugated hyperbilirubinemia, this is bilirubin which was formed from broken heme and was not yet conjugated to glucuronic acid. So the first cause for increased level of unconjugated hyperbilirubinemia is increased production, which occurs when we have hemolytic anemia. We have excessive destruction of heme, giving rise to increased production of unconjugated bilirubin. Usually, hemolytic anemias, the patient presents with very faint yellow color. We call it the lemon yellow jaundice. He also presents with features of anemia. After all, he is a patient with hemolytic anemia, so he has features of anemia: pallor, fatigability, breathlessness, dyspnea. All manifestations of anemia can present, together with splenomegaly, which occurs for two reasons: either because the spleen wants to replenish the stores of hemoglobin and shares the bone marrow in production of hemoglobin, or because the spleen is a major site of the reticuloendothelial system and is responsible for breakdown of the extra heme. So they have anemia, splenomegaly, together with the faint lemon yellow jaundice. And in addition to this, the extra bilirubin, which the excess bilirubin which gets destroyed leads to production of high level of unconjugated bilirubin, and the liver can conjugate more than the usual conjugated bilirubin. So we have also increased conjugated bilirubin inside the biliary system, and the high concentration of conjugated bilirubin inside the biliary system facilitates formation of what we call pigment gallstones. So these are the features of patients with hemolytic anemia presenting with unconjugated hyperbilirubinemia. The second cause for unconjugated hyperbilirubinemia, when the production is normal, but we have impaired uptake of the liver. The production is normal, but the liver doesn't uptake the hyperbilirubin, and this is what we call Gilbert syndrome. We find it incidentally in adults. It's an incidental finding. Usually, this adult person does not complain of anything. He's healthy, living in a normal life, but someday someone tells him that his eyes are a little bit yellow, and he starts to seek medical advice. And we find that all that he have is indirect hyperbilirubinemia or unconjugated hyperbilirubinemia, but all other liver labs are normal. We have liver biochemistry are normal, normal liver enzymes, AST, ALT, normal virology, etc. So we just reassure the patient this is an inborn error where he has a diminished ability or the uptake of unconjugated bilirubin. It will not cause him any harm. It's just an incidental finding, just a yellowish discoloration of his eyes in some days, especially when he's fasted or when he has a mild illness, a common cold. This is the second cause for unconjugated hyperbilirubinemia. The third cause for unconjugated hyperbilirubinemia is when the production is normal, uptake by the liver is normal, but we have a defective conjugation. And defective conjugation, this is what we call Kriglar syndrome. It's a metabolic error. It's which is hereditary. We have two types, type 1 and type 2. One of them is complete absence of the responsible enzymes for conjugation, and one is just a deficiency of the responsible enzyme. One of them is dominant in inheritance. The other is recessive inheritance. Normally, we have a normal liver histology, but the problem is this occurs in neonates, and in those neonates, they have an incomplete blood brain, and because the unconjugated bilirubin is water insoluble and it is fat soluble, it can enter through the incomplete blood-brain barrier into the brain tissue, because the brain tissue is rich in fats. And when it enters the brain tissue, it can cause kernicterus or affection of the basal ganglia in the new, and this can be fatal. They do not respond to the usual therapies that a newborn receive for neonatal jaundice because they lack the enzyme responsible for conjugation. So the only treatment for patients with complete absence is liver transplant. So these are the causes for unconjugated hyperbilirubinemia. Either the production is increased like in hemolytic anemia, or the uptake by the liver is reduced like in Gilbert syndrome, or the enzyme responsible for conjugation is absent like in Kriglar and Jaundice. The other major type of hyperbilirubinemia is the conjugated type of hyperbilirubinemia, and this is what we call cholestatic jaundice. It's chole because chole means bile, static stasis, so it's obstruction of bile or obstructive jaundice or conjugated hyperbilirubinemia. All three terms can be used interchangeably. They are all the same thing. Bilirubin is conjugated in the liver, but it is not excreted in the bile. And this obstruction can be either extrahepatic obstruction or intrahepatic obstruction. When we speak about extrahepatic obstruction, this is the obstruction of the bile duct itself. And any obstruction of any duct in our bodies or any, we can classify it further into either intra-abdominal obstruction, like by stone in the common bile duct, or some parasites which inhabit the common bile duct. It can be luminal, meaning in the wall itself, like repeated inflammation and fibrosis, like in sclerosing cholangitis, or tumors affecting the wall like cholangiocarcinoma. Or it can be extraluminal pressure from outside, either by lymph nodes or by the pancreatic head masses. The common bile duct passes through the pancreatic head, so patients with pancreatic head masses, these masses can obstruct the bile ducts and cause obstructive jaundice. These are the causes of extrahepatic bile obstruction. Intrahepatic bile obstruction occurs in primary biliary cirrhosis, occurs in Dubin-Johnson-Rotor syndromes, in some drugs toxicities, and in patients with sepsis, and also occurs in hepatocellular jaundice. It can occur because of one of the following four mechanisms: either inhibition of sodium-potassium increase in basolateral membrane, decreased transport across sinusoidal plasma membrane, damage to tight junctions, or bacterial cell edema. The next slide will explain this and will elaborate the things in a clear way. If we imagine that the liver has excreted some conjugated bilirubin inside the bile ducts, and they reach the intestine, and at the terminal ileum, they get absorbed from the terminal ileum, and they come again to the liver through the portal blood in the enterohepatic circulation. When they come to the portal blood, the mission of the liver now is to re-access conjugated bilirubin from the portal circulation and re-excrete it in the bile canaliculi. To form this, the liver needs special transporters lying in the cell membrane of the hepatocytes, and these transporters need some energy with ATP delivered by sodium or helped by sodium-potassium ATPase. And when these are available, they reuptake the conjugated bilirubin from the portal circulation back to the hepatocytes. And when back to the hepatocyte, they are re-excreted once more into the bile canaliculi. So absence of these transporters, like in some congenital anomalies, this is the Dubin-Johnson and Rotor syndrome, we have error of these transporters, or dysfunction of sodium-potassium ATPase and lack of energy supplying these transporters can prevent the liver from reuptake of conjugated bilirubin, and the conjugated bilirubin stays in the bloodstream, elevating the level of conjugated bilirubin in the bloodstream. This is because it's not an obstruction in the bile duct, but it's like a virtual obstruction because the hepatocyte did not take the conjugated bilirubin and excrete it once more into the bile canaliculi. The bile canaliculi themselves, they don't have a wall of their own. Their walls are just the walls of the hepatocytes. Two adjacent hepatocytes have their walls modified to form the bile canaliculi. When the conjugated bilirubin enters from the bloodstream to the hepatocytes to the bile canaliculus, why does it not escape back to the blood from between these two cell membranes? Because the bile has not a wall of itself. It's just the wall of the adjacent hepatocytes. It's because of tight junctions closing the distance here, and causing the bile canalicus to be segregated and partitioned from the space of this and from the portal circulation. So any disease which interferes with tight junctions, like in sepsis and like in some drugs, some drug toxicity, can lead to escape of the conjugated bilirubin back to the bloodstream, as if the blood the conjugated bilirubin is not excreted, as if there is an obstruction. It's a virtual obstruction. It's not a true obstruction, and that's why you call it an intrahepatic obstruction or intrahepatic cholestasis. And the last reason was in the hepatitis, in hepatocellular jaundice. In hepatitis, we have inflammation of the hepatocytes. And when these cells get inflamed, one of the major manifestations of inflammation is edema. And when this cell is edematous, the other cell is edematous, and these walls get towards each other, and they cause an obstruction of the bile canaliculi, but this time it's an obstruction again inside the liver, so it's again an intrahepatic cholestasis. So these were the causes: either inhibition of sodium-potassium ATPase, decreased transport across the sinusoidal plasma membrane, damage to tight junction, ductular cell edema. These were the mechanisms responsible for intrahepatic cholestasis, and it occurs in primary biliary cirrhosis, Dubin-Johnson-Rotter syndrome, drugs and sepsis, and in hepatocellular jaundice, which is hepatitis. How do we approach the patient? Whenever you are asked about a clinical approach in any exam, if you are asked about a clinical approach, you should start always by the history taking. And history taking in the patient with jaundice, you start by the color of urine and color of stool. Why? Because we mentioned that the color of stools is in part caused by stercobilin. So presence of dark stools means there is stercobilin, and that means there is no jaundice. While in obstructive jaundice, there is no stercobilin, and the stools get pale in color. So absence of stercobilin, obstructive jaundice causes pale stools and dark urine. We also ask about itching. We also ask about itching or uritis, because with obstructive jaundice, it's not just obstruction of conjugated bilirubin, but it's also obstruction of bile salts. When bile salts diffuse back through the portal circulation and escape the liver to the bloodstream, they get deposited in many tissues, including the skin. Whenever these bile salts get deposited, they cause damage. Bile salts are injurious. Bile salts have a structure similar to the building blocks of our cell membranes, and that's why they can integrate themselves to cell membranes and cause disruption of the cell membranes and leakage of intracellular content, causing inflammation. So when this occurs in subdermal tissues, it causes itching, it causes pruritus. We also ask about fever, and we ask about fever because it occurs in patients with hepatitis, it occurs in patients with liver abscess, it occurs with patients with cholangitis. It's again an inflammation. We ask about abdominal pain to exclude biliary colic and to exclude pancreatic pain associated with pancreatic masses, which is one of the causes of obstructive jaundice. We ask about drug intake and interfere with bilirubin metabolism at various stages and various levels, at the level of uptake, at the level of conjugation, at the excretion, at multiple levels. Drugs can interfere. We have a long list of drugs. So simply you ask the patient what drugs is he taking, and we search if this drug has some relationship to jaundice or not. We ask the patient about blood transfusion and intravenous drug associated with hepatitis B and C. And we ask about family history because autoimmune hemolytic anemia or hemolytic anemias have family history because primary biliary cirrhosis has usually there is also a family history, and autoimmune hepatitis can have family history. So these are the important aspects of in history taking in patients with jaundice. The second item in clinical approach is examination, and we examine for signs of liver disease. We examine for itching marks, dental asthma. Dental asthma is lipid deposition under the skin, especially in the eyelids, because the eyelids are very thin. They occur in patients with, again, in obstructive jaundice because they have hypercholesterolemia. The bile acids is one of the catabolic end products of cholesterol in obstructive jaundice. When we have rise in bile acids, they inhibit their own genesis, their own formation is inhibited, and thus the cholesterol is not destroyed, and there is hypercholesterolemia causing melasma. We ask about bradycardia, which is associated with viral infections and associated with obstructive jaundice. We ask about lymphadenopathy because if the patient has lymphadenopathy, we might think of lymphadenopathy in the porta hepatis causing obstruction of the bile duct, again obstructive. Splenomegaly is present either as a sign of liver disease, portal hypertension, or it is present in hemolytic anemia. So we have to examine for splenomegaly. We examine for liver like in cirrhosis, a tender liver like in hepatitis, or an irregular liver like in malignancy. And we examine for ascites as a manifestation of liver disease. Next step after examination is investigations. And we start liver biochemistry. We check the bilirubin, whether conjugated or unconjugated bilirubin is elevated, so that we can investigate further what is the pathology behind this jaundice. We check the liver enzymes. AST and ALT are usually elevated in inflammation of the liver cells in hepatitis, while gamma glutamate, that's phase, and alkaline phosphatase are elevated in patients with obstructive jaundice. We check the prothrombin time and albumin level to assess for chronic chronic hepatocellular function. We assess the viral markers for hepatitis A, B, and C. Hepatitis A is one of the most famous causes of jaundice. We check CBC because hemolytic anemia is one of the causes of jaundice. We check the autoimmune profile is important for two conditions. For autoimmune hemolytic anemia and hepatitis and primary cirrhosis, they are associated with different antibody profiles in the lab. Then we come to imaging. And we start imaging by abdominal ultrasound. Abdominal ultrasound is very safe. It's very simple. It doesn't harm the patient. It's non-invasive. It can be in some clinics. It's a bedside test in some of our clinics. So we start by abdominal ultrasound, and abdominal ultrasound can detect gallstones. In this picture, we see this is the liver tissue, the cut section of the liver, and on the underside of the liver, we have a pyriform shaped area with black inside. Both black means fluid, so this is a pyriform area with fluid inside. This is the gallbladder. And inside this black, we have shadows, white shadows, and these white shadows are shadows of gallstones inside the gallbladder. This is another view. Again, the liver tissue, the gallbladder, and gallstones inside the gallbladder. Second item in ultrasound after gallstones is intrahepatic biliary radical dilatation and assessment of common bile ducts. In this picture, we see this is the portal vein. Usually in adults, the portal vein is about 8 millimeters in diameter. And, the common bile duct is usually 3 millimeters in diameter. But in this picture, we see that the diameter of the common bile duct, diameter of the portal vein are almost equal. This means that the common bile duct is dilated, and it is dilated because of this obstruction. So this means an extrahepatic biliary obstruction. Another view with dilated intrahepatic biliary radicals. We see that biliary radicals are dilated. They are usually not seen like this. When we see this, we know that they are dilated, and we know that there is an obstruction outside. And here we see the cause of obstruction is mass, delimited by these two arrows. We see a mass occluding the common bile ducts. Another view with a portal vein, common bile ducts, and we see that both are equal in diameter. Again, dilatation and extrahepatic obstruction. We also assess the pancreas by ultrasound, but the pancreas, being a posterior structure, is sometimes difficult to be seen by the ultrasound, and it's not seen except in thin people with low amount of gases in their abdomen. We can see then the pancreas. Otherwise, the pancreas is usually difficult to be assessed by abdominal ultrasound. We also use the abdominal ultrasound to assess the liver itself, to assess for chronic liver disease. Next step in imaging is CT abdomen. And we use CT abdomen whenever we want to visualize things that cannot be visualized by abdominal ultrasound. The pancreas, being a posterior structure, being masked by gases usually, and in obese patients cannot be seen by ultrasound clearly, and we can resort to CT abdomen to examine the pancreas, or magnetic resonance imaging to examine the pancreas. Magnetic resonance, like CT, they both are imaging which can see the pancreas, but the magnetic resonance has two benefits. First, it's less hazardous. It doesn't have radiologic hazards like CT. And second, there is a modality in the MRI which is called MRCP, magnetic resonance cholangiopancreatography. This is a special modality where we can see the ducts of the whole biliary system. It is delineated. We can see whether the biliary system is dilated or not, and whether there is an obstruction inside the lumen or not. So MRI has an additional benefit of providing us with magnetic resonance cholangiopancreatography. The other way to see the biliary tree and the pancreatic duct is by endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography, we introduce our endoscope through the esophagus, stomach, down to the duodenum. And when we reach the second part of the duodenum, our endoscope is just in front of the ampulla of fat with the common bile duct. And use a very long cannula, and from the ampulla of water upwards along the common bile ducts, and then we inject a dye, and we by plain X-ray we can see the dye inside. Since we introduced our cannula by the endoscope, it's endoscopic. Since we introduced our cannula from below upwards against the normal flow of bile, It's called retrogrades and cholangiopancreatography. This is the picture we usually see. It's not this is the picture we see usually. These are the biliary radicals. We see that the endoscope is much thicker than the common bile duct. This is a normal bile duct with the normal biliary tree, and the piriform shaped thing here is the gallbladder. While in these two pictures, we see that the bile duct has more thick than our endoscope. So this is a dilated biliary duct with exits, and the view of a dilated bile duct with multiple fillings inside dilated biliary tree. This is biliary obstruction due to gallstones. Sometimes we cannot introduce our cannulas through the ampulla of fata. The lesion is too tight, or because there is a mass occluding the ampulla of fata. And here the next modality we can resort to is PTC, percutaneous transhepatic cholangiography. We introduce through the skin, between the ribs and the intercostal spaces, through the liver tissue, and under ultrasound guidance, we inject the needle in one of the biliary radicals. Since they are dilated, we can easily introduce the needle inside one of them, and then we inject the dye to see the biliary radicals. But this time, the way is different. It's not an endoscopic, it's a percutaneous transhepatic cholangiography. We can also remove the needle and connect something to collect a bag to collect bile from these biliary radicals, and we then call it percutaneous transhepatic drainage instead of cholangiography. It's one of the therapeutic modalities we can resort to. And last but not least, we have EUS, endoscopic ultrasound. The problem of the pancreas is that it is a posterior structure. It's not clearly visible in abdominal sound. But if we introduce a scope and the scope, then the ultrasound probe is in the very close region on the biliary radical, and we have an ultrasonic picture of the pancreas, the common bile duct, portal vein, gallbladder, and any masses can be seen inside the pancreas. So this was the clinical approach, how we take the history, how we examine, and then how we investigate by labs and by imaging. How we manage the management of unconjugated hyperbilirubinemia is usually the management of the cause. If it is hemolytic anemia, we manage hemolytic anemia. Gilbert, we just reassure the patient. But for cholestatic jaundice, we have other things to do, additional things. If there is obstruction by stricture or by mass, by stones, to surgery to alleviate this obstruction, to relieve the stricture, to remove the mass, the stones, we can receive management. But before surgical management, we have two modalities. Internal percutaneous transhepatic drainage. It's like PTC, but we collect the bile from the through the or by doing an ERCP, instead of just inserting a cannula and taking an image, we can insert tools to crush a stone or to dilate a stricture or to insert a stent to inside the stricture. So this is the interventional management of extrahepatic cholestasis. And we have medical management. Medical management, we should have proper hydration of the patient. because bile salts are injurious to most tissues, including the kidney, are prone to have renal failure due to elevated bile salts in their bloodstream. Proper hydration can avoid this renal failure. We can give the patient cholestyramine. This is a bile salt binder, which binds the bile salts so that they are not absorbed in the terminal ileum, do not enter the enterohepatic circulation. We can give the patient also deoxycholic acid, and this acts by replacing by non-injurious bile acids. We give the patient vitamin K because these patients have a lack of absorption of soluble vitamin, which is important for production of prothrombin. If we send the patient to the surgeon or to the endoscopist or ERCP, we need that this patient does not bleed during the endoscopy or during the surgical procedure. So we have to give him vitamin K, and we give the patient antibiotics in inflammatory conditions like coronavirus or like in liver. I hope that it was clear. Unfortunately, in Microsoft Live, I don't have enough feedback. But I hope it didn't. Thank you.